Today, we're going to talk about antibiotic stewardship in urology, managing urinary tract infections without over-relying on antibiotics. I see I left out the I. It's a strong start to our talk. I didn't get the title slide correct. So I just want to give a little bit of background on how we got our research started and why we invited Parsa to come here to join us in the lab. And this work has all been done with Beryl Martin, who's really the backbone of our lab, and he's been a fantastic partner in research for years. And I'm really glad he's here as well to help discuss and defend our project. We're in a little bit of trouble. I found the pretty face behind the project, and this is the muscle, but I guess it's a lower bar for Dr. Martin. We'll talk a little bit today about spina bifida, which are basically infants born with neural tube defects, meningeal lipoma of the cord. This can affect how our neural circuitry works to our bladder and our colon. And we know these children, mostly older patients, will have voiding issues. And this can affect our bladder function. It can affect overactivity of the bladder. You can get overdistension of the bladder or high pressure bladder from detrusor overactivity. You can have difficulty relaxing your external sphincter, causing higher voiding pressures. You can have open bladder next or external sphincter, reducing your pressure. But ultimately, what we worry about is how this is going to impact the development of our urinary tract system and the impact it may have on our kidneys. And if you're having trouble emptying your bladder, this urinary stasis can put you at risk for urinary tract infections. And if it's under high pressure, you could get reflux of urine from the bladder back up to the kidney. If you get an infection in your bladder, that infected urine can reflux to cause that infection of the kidney. So in this population, when we study the children, subsequently older patients, and we can see that they may be having high bladder pressures in that setting with overlying infections from the urinary stasis can really put these patients in trouble. And to mitigate that, historically, we've had patients catheterized. They manually decompress their bladder, whether it's through the urethra or we give them a appendicovesicostomy and mitrofanoff. We're trying to create mechanisms to decrease these bladder pressures. Ultimately, there's other aspects such as continence, but focusing mainly today on urinary tract infections. And if we can empty the bladder on a regular enough basis, typically we can mitigate a lot of these infections just by keeping the bladder decompressed. Now, the concern here is that we do see a significant percent of infections in this patient population. 50% of children with spina bifida will have urinary tract infections by 15 months old. 81% will develop infections by the time they're 15 years old. Recurrent infections are very common. 44% of these children will have greater than 5 urinary tract infections. 10% will have well more than that. Now, this is a little bit of murky territory because how we define urinary tract infections isn't always clear. Now, in this population, there's definitely some aspects where we see patients having true infections. We'll see children having renal scarring. You can see during this DMSA scan. Some people do propose that all children should be assessed with DMSA scans to really see the impact on their kidneys. There's different management strategies, but here just focusing on the impact of infections. So if a patient presents to the emergency room who catheterizes their bladder, and just by catheterizing your bladder, you can have bacteria in your bladder. By default, they show up, they have fevers. The assumption is they have a paravalvular urinary tract infection. They're going to get treated with antibiotics. They're going to get over-treated often in the case, and we start selecting for multi-drug resistant organisms. So here we have this kind of complex problem where you have children with complex conditions with high pressure bladders and high risk for urinary tract infections, which meant high risk for kidney scarring, that we're trying to mitigate some of these risks of the kidneys. And how do we do that? And part of the issue is that if we look at this patient population, we know that when we check their bladders and check the urine, we don't always have a kind of consistent definition of what an infection is. We're not treating everyone equally. Now, if you come in and you have bacteria in your bladder, the assumption is that it's going to be urinary tract infection. But if you look at the infections in this patient population, often they're not E. coli infections, which is the most common infection we'll see in the general population. From multiple rounds of antibiotics, we start selecting for multi-drug resistant organisms, and urosepsis is really much higher in this patient population than the general population. So we're careful. We do want to treat. We want to prevent infections. Now, the question is, how do you strike that balance? And if you just look, and I'm just giving you kind of a couple short examples, but if you look at different studies, in Varda's paper, they looked at overtreatment. And you can see here in the gray box, these are the patients, this circle, the A is the patients that were treated for infection. But you're trying to create different parameters to define what a true infection is. So you can say that they have bacteria in their urine, positive culture, that they're symptomatic, they have pyuria, And you look for the kind of Venn diagram to see how they overlap and see which of these truly need to be treated for infection. And all of this shaded area are what they're considering overtreatment. And if you're overtreating all these patients, you're going to start selecting for a lot of multi-drug resistant organisms. So what we wanted to do in our project was try to find ways to mitigate infections. We have these high resistance patterns. We know this is a global concern. We want to try to find new therapies, and there's not a lot of new antibiotic alternatives or non-antibiotic alternatives that are kind of keeping pace with this resistance that we're selecting for. So we wanted to try to identify ways to mitigate infections in this population. We want to see if we can reduce the bacterial load, or we can sterilize the bladder. We want to reduce the selection of multi-resistant organisms, and we're going to ask Rezaeian to come up and talk about some of the research he's done and ways that we can try to find to treat the bladder, to try to see if we can reduce infections. Come on.
Well, hello everyone. I hope all of you had a great time during Thanksgiving. My name is Ahmadreza Rezaeian. I'm known as Parsa. My topic is antibiotics, stewardship in urology, managing UTI without applying antibiotics. First of all, I should say that we are a team, so I'm here on behalf of the team. Dr. Hittelman and Dr. Martin and I are working together on this project. And here is the outline of the topics I'm going to talk about. I will just briefly introduce UTI again, and then I will go for antimicrobial reagents for in vivo and in vitro assessments that we have done in our lab, and some safety and efficacy data of our treatments. So first of all, why UTIs should be important to urologists. As you know, UTI is among the most common infections, and it costs about $6 billion annually to the United States. Around 11 million patients are referred to healthcare system because of the UTI, and approximately 500,000 patients got hospitalized because of the UTI. And as you know, it can affect women, men, and children, and it will be problematic in patients with spinal injuries, with multiple sclerosis, and the patients who need catheterization. Although we have lots of advances in treating UTI, still the gold standard treatment would be antibiotic. And WHO described antibiotic resistance in uropathogens as a key pressure point in the growing global antimicrobial resistance crisis. So let's just talk briefly about the biology of the UTI. As you know, first of all, the GI flora should colonize around the urethra, then the bacteria can climb the urethra, reach the bladder walls, and using type 1 pili, they can attach to uroplakin, internalize as the cells, colonize there, and form some IGCs, which stands for intracellular bacterial colonization. And by shedding and infecting neighboring cells, they can just grow and even cause recurrent cystitis. So how we can decrease antimicrobial resistance in the field of urology? First of all, I want to talk about the ideal way to treat UTI, which would be the right drug at the right dose, at the right time, the right target, and nowhere else. So in that case, we can maximize the safety and efficacy of the drug, and at the same time, minimize the cost and burden of the disease. We have two great proofs in the field of urology for intravesical treatments. As you all know, intravesical chemotherapy for the bladder cancer and injecting Botox into the intercostal muscle would be two examples of intravesical treatments that were successful in the field of urology. So what would be some candidates for intravesical treatments for UTI? Here you can see 8 reagents, including antibiotics, cationics, metal ions, detergent, cranberry, hyperosmotic, weak organic acids, and isotonic solution. I'm going to talk about the mechanism of action of these reagents. So briefly, cationic acid are positively charged. They can bind to the negatively charged cell surface and lead to loss of the intracellular contents. Metal ions can generate reactive oxygen depletion, which can just damage the macromolecules of the cell. Cranberry effect is by preventing adhesion of the E. coli using 2 different components, fructose and fructose cyanidine. And weak organic acids like vinegar, they use acidification of the cytoplasm, and they can inhibit the biosynthesis of the cell. detergents, their effect is just mechanically they suspend the cells into solution and just help the host to physically remove the cells. And hyperosmotic shock, like high concentration of the sodium chloride, can increase the external osmolarity around the cells and lead to shrinkage of the cells. And the last two ones, antibiotic as our positive control, is the one can inhibit the bacterial protein synthesis. And the isotonic solution like saline is a negative control. The only way it may decrease the bacterial burden is just the irrigation. It doesn't have anything else to do. So let's start with our data, our in vitro data in our lab. We use UPEC UDI-89 as our bacterial strain to evaluate our reagents. And we use three different in vitro techniques. First of all is bacterial density using optical density at 600 nanometers. The second one is disk diffusion assay, and the last one is colony forming unit. We're going to talk about this in a minute. So this one is OD600 experiment. As you can see in the left picture, there are some solutions. You made your solution in microtubes with E. coli, the medium for the bacteria to grow, and you add reagents to them. And just picking some drops and using nanodrop machine, you can have OD600 values, which shows the density of the cells in that solution. So doing it serially, you can have a growth curve for the bacterial growth, and you can see what dose of the drug could be toxic to the bacterial. The first one, as you can see here, is gentamicin. We use 0.047 milligram per milliliter, and if you can see my pointer, the black line is untreated microtube, so you can see the OD values is increasing, which shows the cells can divide, the bacteria can just grow, while in the blue line, which is the gentamicin treated microtube, you can see the state is steady and the bacteria cannot grow. Same thing for chlorhexidine. Here you can see the control ones, which can just divide, while others treated with chlorhexidine, they are just inhibiting the bacterial growth. Here, the dose that we use is 0.025%, which is in pink, this one, and you can see the steady state of the bacterial growth. For silver nanoparticles, the dosage that was picked was 5 milligram per ml in the red line, which was successful in inhibiting growth of the bacteria. For the soap, we had to try it multiple times because of some issues. And you can see that 50% was the one who could work here in the pink one, but also we can see even 10%, 50%, 5%, they're still working and they can inhibit the increasing growth of the bacteria. For the cranberry, here still you can see the untreated ones in the black, and you can see the growth curve can reach the value of 5, while you can see for the others treated with cranberry, the numbers are much higher. This technique is not working for cranberry because cranberry solution itself is a colorful solution, so it can just scatter the light itself. So we cannot use OD600 toxic dose for cranberry, and we have to use the other methods. For acetic acid or the vinegar, we pick 2.5% of the vinegar as a chosen dose, which could inhibit the bacterial growth. And the last one is hyperosmotic sodium chloride, which 200 milligram per milliliter could inhibit the growth of the bacteria. So here you can see the second in vitro assay that we use is this diffusion assay. In this method, you spread bacteria on the agar plates, and using some paper disc, you soak them with different antimicrobial reagents, and then just put them on the agar plates. And after 24 hours of incubation time, you check the inhibition zone around the disc and measure the radius, so you can decide how toxic would be the treatment. Just a quick point, in this picture, the disc is written in antibiotic disc. It's because I used the picture from paper that used antibiotic, but here we use different antimicrobial reagents. So in this, I just put some samples here. In the left picture, you can see for gentamicin, and the right one, you can see the chlorhexidine. In the left picture, you can see 3 discs on a plate. For example, the top right is gentamicin 0.45 milligram per ml. The top right is the saline as a negative control, and the bottom one is gentamicin tenfold, which is 4 milligram per ml. And the right picture, the other agar plate is chlorhexidine with two different dosage and saline as a control. So sometimes the disc, the inhibition zone around the disc is not symmetric. So the way we measure it is measuring 4 different directions: top, bottom, left, right, radius around the disc, and we just calculate the average radius and report it to compare the potency of the drug. So here you can see the average in red bars, and if we compare it, the first one is for gentamicin 4 milligram per ml, which was the radius in 7 millimeter, while for gentamicin 0.47, it's like 4 millimeters. And for the saline, as the last one, you can see there is no inhibition. The bacteria could grow everywhere. And the other drugs are in the middle. And for example, you can see chlorhexidine is working well, and the other reagents work differently in different dosage. The last in vitro assay that we use is cloniforming units. In this method, you just exactly the same as the OD60. You just introduce the bacteria with their different reagents. You give them 1 hour incubation time, and then you make a serial dilution. Like the first one, for example, if it's stock, you go for 1 to 10, 1 to 100, 1 to 1,000, 1 to 10,000, and go on. And then pick like 50 microliter of solution, put it on agar, and after the 24 hours incubation time, you have a picture like this. So you can see different reagents in different columns and serial dilution in different rows. The aim here is to reach a plate with 30 to 300 colonies, so you can count it, and you can find CFU of the stock that you're using. The advantage of this technique compared, for example, to OD600 is just evaluating living cells. But for example, in OD600, it's like the density, so you can differentiate if it was a dead cell or it was a living cell. So our result in CFU showed, for example, in untreated, the first bar, it's like 10 to 8 CFUs, while for chlorhexidine and gentamicin, you can see it's nothing. So also good news is for silver nanoparticle and Castle. They're still working, and the CFU are so low, while for cranberry vinegar and high concentration of sodium chloride is not that much promising, at least for this point of experiment. So let's go for in vivo data that we have. First of all, the protocol that we are using for in vivo to model UTI, we are using a nature protocol. 3 main components in this protocol is the animal we are using, the inoculum, and the catheter. The animal we are using is C3H mice, which can develop UTI. The age of the mice is 7 to 9 weeks old, and we are covering both genders, so it's not only for the women or male, for the female or the male ones. And about the inoculum, again, we are using UTI 89, which is clinically isolated UPEC. We want to be sure that they can form type 1 pili, so we use a specific way of culturing. They need 2 overnight culturing in the incubator without any shaking. And the concentration of the suspension that we are using is the OD. Using OD is like 0.4 to 0.5, which is equal to like CFU 10 to 7 or 10 to 8. About the catheter that we're using, catheter would vary in length and the gauge of the needle or catheter that you are using, and it could be different in different genders. All the time, we sterilize the catheter with UV to just decrease the contamination risk. Here in this picture, I'm just showing you a picture of a paper. They catheterize a female mice, and in the top left, you can see a nose cone. So we first anesthetize the mice, and they go for installation of your solution. Comparing to the male one, you can see it will be much harder in male one. in the mouse, they have two purposes. You have to slide them back, reach the penis, and since they're so tiny and fragile, you should be so careful for the traumatization. And using some lubricants, you can catheterize them and instill solution. One important point that we should mention here about male catheterization is the different anatomy that they have in mice. As you can see, the genitourinary system of the mice is like in this picture. You can see the ventral prostate, seminal vesicle opening are close to a bladder neck. So during the catheterization, you should be careful about catheterizing bladder correctly, which is relying on the catheter that you're using, the length of the catheter that you're using. Here, I'm just showing you a picture that you can see in the left one. Correctly, you catheterize the bladder, you stain it with some dye, while in the right picture, you can see using not correct catheter can just result in instilling in the seminal vesicle instead of the bladder, so you cannot develop any UTI model. So let's talk about our result on inflammatory response to UTI. First of all, we did a time course. We instilled inoculum into the bladder of the mice. We did harvest the bladder after 1 day, 3 days, and 7 days. And using immunohistochemistry, which is a method to just evaluate the tissue, and using two antibodies, anti-CD45, for measuring inflammation response, and anti-E. coli, we can just evaluate and measure the inflammation response and how a bacterial population is in the bladder. The results shows in the first day compared to third day and seventh day, the bacterial population is much higher, and you have more IBCs in the bladder. While when it longs later, the inflammatory response in the post would be greater. And if you want to measure inflammatory response, it's better to wait more. And the last point of this experiment was female inflammatory response was much higher compared to the male one, which would be an interesting point to be considered. Here, there are some samples of our experiment. First of all, when you can see urothelium here, this layer is urothelium. The brown dots are the positive cells. So in the top left, you can see this first day male mice, which was undertaken immunohistochemistry with anti-E. coli, and you can see the IBC here, which shows the bacterial population in the bladder perfectly. And in the top right, I used another picture in third day female, again anti-E. coli, and you can see still we have IBC there. In the bottom two pictures, the left one is the male one, and the right one is the female one. They're both stained with anti-CD45, which is reflecting inflammation in the bladder cells. And if you can see my pointer, these tiny brown dots are represented as white BCs here compared to the female one, which you can see the density is much more higher. The second experiment that we've done is about concentration curve. We thought about different ODs and the higher concentration of the bacteria, how it can affect the result. Can it cause more bacterial population in the bladder and more inflammation? So in this experiment, we used 3 different ODs, 0.45, 0.50, and 0.55. And again, we just did immunohistochemistry to compare the results. And as you can see, the bacterial population and inflammation response was greater in higher concentration of the inoculum. But another important thing that we found here was male mortality was much higher compared to female one. So most of the male mice got sick, and we have to euthanize them early. So you maybe think that it would be surprising, but after checking some evidence, you can see there's some evidence showing that male urinary tract infection would be really severe compared to female ones. And in this paper, Olson et al., using a surgical technique, they just inoculate the bladder with the bacteria, and they figure out that in the male one, chronic cystitis, pyelonephritis, and abscess would be more severe. And these phenotype in the male one would be stopped after castration, while after giving them the exogenous testosterone, you can restore that. So they're just showing that there is a relationship between testosterone and the UTI inflammation. How inflammatory system is responding to UTI, and it could be a explanation for our result why male mice are getting sicker and die. So we went further to exhibit male higher susceptibility to UTI. Here is another experiment that we designed. So we wanted to figure out if bacteremia is happening in the male mice. In the bottom diagram, you can see in the first hour, we just introduced the bacteria to the bladder, and we did collect blood samples after 1 hour, 4 hour, 5, 6, 7, and 10 hours to confirm the bacteremia, and we cultured the blood that we obtained from the mice. Here is a sample. You can see the first column is 4 hour, the second one is 7 hour, and the third one is at 10 hours post inoculum. And the top row is the blood samples, and the bottom row is urine samples. So you can see bacteriuria is happening in all of them, while bacteremia is not happening till 4 hours, while after 10 hours, you can see it's pretty severe in the blood. So we went to even evaluate the tissue, not only relying on the blood. Again, we did immunohistochemistry for anti-E. coli antibodies, and we could see that like the IBCs that we had in the bladder, we can have some IBCs in the kidney, we can have some bacteria in the spleen and liver, and they're all showing us that even organ involvement is happening in these male mice. So the other topic I want to talk about is the safety of the treatments that we're using. We designed a drug toxicity evaluation. Again, we instilled our reagents intravesically, and we harvested the bladder after 3 days, 7th day, and using immunohistochemistry and anti-CD45, we just evaluated the inflammation response. And we found that the peak dosage of the reagent were safe to the bladder, so it was okay to use it as a treatment, while the 50% dilution of the soap, it was getting somehow toxic to the mice, so the mice felt sick, and we have to euthanize them. So we diluted to 5%, which was tolerable for the mice. And for the cranberry, problem we had was cranberry is like a suspension, and you cannot solve it perfectly, so it can block the angiocathode that you're using. So the highest possible concentration that you can use for cranberry is 25 milligram per milliliter. You cannot go higher, otherwise you can't control the dosage that you're using. So now we know for the male mice, till 4 hours after inoculum installation, still no bacteremia is happening, while after 10 hours we have bacteremia. And also we know our treatments, our reagents are safe to the bladder. So we want to evaluate if our treatments can delay the bacteremia happening in the male mice. So we designed this study using low concentration of the bacteria, OD 0.45, and 5 different groups. First one is gentamicin, second one chlorhexidine, singular nanoparticles, so 5% dilution, and the saline one. And here is the study design. So you introduce the bacteria to the bladder cells first in 0 time, 0 hour, and after that you just clip the urine route to keep the inoculum in the bladder for 1 hour. And after the first hour, you just empty the bladder. After 3 hours, you do the treatment. You instill the reagents like chlorhexidine, gentamicin, whatever. Again, you keep the reagents in the bladder for 1 hour. And after 10 hours, you do the cardiac puncture to collect the blood samples and do blood culture. So here is the result. You can see in the first two columns that there are saline ones. The third to fifth column is 5% dilution, and the last one is gentamicin as a positive control. The top two rows are the urine samples, 1 to 10 and 1 to 100 dilution, and the last two rows are blood samples, again 1 to 10 and 1 to 100 dilutions. As you can see in the saline one and the 5% dilution, the bacteremia still is happening and it's not working. While in gentamicin as a positive control, you can see the bacteremia is perfectly prevented. So here I'm showing you two other reagents, silver nanoparticle and chlorhexidine. You can see after 10 hours, the same procedure that have been done. And in silver nanoparticles and chlorhexidine, you can see the bacteremia is prohibited. So it seems, at least according to this experiment, intravesical treatment of silver nanoparticles 5 mg per milliliter and chlorhexidine 0.025% can delay antibiotic prescription for this UTI. The other thing we thought about is adding a second dosage of the treatment to see if we can, just increase the efficacy of our treatment. Here is the study we designed. We again used same ODs, 0.45. We went for 3 groups: gentamicin, chlorhexidine, and silver nanoparticles. And it's the way that we followed. So first, we prepared the inoculum. In the first hour, we did the first catheterization, which was bacteria introduced into the bladder. 3 hours later, were the second catheterization, which was the treatment. The first treatment, for example, silver nanoparticles. And after 3 hours, we did another treatment with silver nanoparticles. So the difference here is we did 2 silver nanoparticles instilling into the bladder to see if the efficacy is increasing or not. And here we have blood samples, 14 hours, 16, 18, 20, 22, and 24 hours post inoculum installation. Here is the result of this experiment. As you can see, because the saline group cannot survive, they're sick, they're in pain, so we won't let them to suffer. We usually euthanize them earlier. I just show them with a tiny red point here that it would be the maximum CFU in the outer plates of the saline ones compared to the silver nanoparticles in this blue line. And chlorhexidine in this dark blue and gentamicin in the green line. You can see that the treatment is helping the infection to be at least delayed for causing bacteremia. But the thing that we should mention here, that was the aim of this study, was to see if the second dosage of the treatment can help the host to just prevent bacteremia, while when comparing to the first experiment, which was just 1 dosage of the treatment, we could see the result is not that much promising. So second dosage wasn't that much helpful. The picture here could be a bit misleading because the scale is so high. So you may think that chlorhexidine is working like gentamicin, while when you follow the survival rate of the chlorhexidine mice, you could see 2 out of 5 mouse needs to be sacrificed after 27 hours, while the others needs to sacrifice after 30 hours, comparing to gentamicin, which they can survive longer. And what would be our next steps? Our next steps for this experiment would be, first of all, we want to use another UPEC to just confirm second strain of the bacteria to be sure that our result is repeatable. And using another, antibiotic resistance E. coli, we can confirm that the colonies that we're seeing in argoplates are not contaminations, and they're exactly the bacteria that we're looking for. The second one would be modifying the interval between treatments. We thought that 3 hours between 2 doses of the treatments for the silver nanoparticle and chlorhexidine might not be ideal and can go for a longer one to see if it can help UTIs to be treated. We just focused on bacteremia in these experiments. We want to even go for organ involvement to see if treating with Aricept, chlorhexidine or silver nanoparticle can decrease the number of IBCs or no. And the other thing that we are thinking about is combination therapies. For example, we can combine silver nanoparticle with chlorhexidine and try it again to see if the synergistic effect is happening. And at last, we should design another study for the female mice to compare the result of the reagent that we're using with male ones.